Thank you so much, Joanne. I am actually going to hand it to Lila Rabinovich for the next panel, which is on physical and mental health and well-being. Thank you again, Joanne, and I hope you get some sleep.
Hello, everyone. Can you hear me okay?
Yes.
Yep, great. So as Tara said, welcome to our first thematic panel on physical and mental health and well-being. We have 3 speakers today. Our first speaker is Wandi Bruin, and I hope that I pronounced that correctly. We had a long debate yesterday about this point. She is a provost professor of public policy, psychology, and behavioral science at the University of Southern California. She's also affiliated at USC with the School of Public Policy, the Department of Psychology, the CIPHER Center for Health Policy and Economics, and of course, the Center for Economic and Social Research. Her work is on the psychology of risk perception and communication, and she currently serves on the National Academy of Sciences Committee on Mask Use and Respiratory Health. And she will be talking to us for 10 minutes as a reminder, and then we have 5 more minutes for questions, and then the second and third presentations afterwards. So Wandi, take it away.
Thank you, Lila. I hope it's okay for everyone. I'm on this meeting twice. My sound is coming from my phone and my video and slides are coming from my laptop, but you can hear me okay, right? Great. So it's a pleasure to be here today, although it's a little bit bittersweet because the last conference I spoke and participated in person was CIPHER 2020. So I hope next year we can do this in person again because it's such a great group. So today I'll be speaking on effective vaccine allocation strategies on vaccination refusal and protective behaviors. This is a paper I worked on with Alona Ukinaku, who is a professor of marketing at the University of Leeds Business School, as well as Dana Goldman, who's a health economist at USC. And I want to thank our various funders who have funded data collection at the UAS, as well as some of our time. So as many of you are probably experiencing, due to limited supplies, some people will have to wait for the COVID-19 vaccine. And marketeers like my colleague Alona warn that missing out on a product reduces people's desire for it. So we're a little bit concerned that if people have to wait for the COVID-19 vaccine, that they may no longer want it. And while we were working on our project, we also got concerned that people might be especially less willing to get vaccinated if they see others getting vaccinated first that they don't believe should be vaccinated first. And people agree on vaccinating healthcare workers first, but not on who should be vaccinated next. So in a nationally representative US sample, we examined people's preferences for vaccine allocation and the effect of vaccine allocation strategy on willingness to vaccinate and socially distance. So we did this work on the UAS, which you've heard a lot about today. The UAS has been running surveys every 2 weeks since March 2020 about COVID-19 risk perceptions, protective behaviors, and so on. And so it's amazing data that's publicly available. But what's also possible with the UAS is there is this ability to add your own questions if there are any pressing topics that need to be covered. And so we funded a couple of extra questions to be added to the March-April 2020 survey. I won't talk more about the UAS. We've heard a lot of detail about it already. But if you have any questions about the methodology, I'd be happy to answer afterwards. So first, let's look at people's preferences for vaccine allocation. We asked people after healthcare workers, who do you think should be vaccinated next? And then they saw one of these, they saw this list of 5 groups in random order. And these groups were selected from different expert recommendations that we had come across. And so the first group is people at high risk of getting sick or dying from COVID-19 while living in group housing. For example, people who are older, have heart disease, diabetes, and other health conditions. The second group is basically people at the same risk but living with their families. Third group is people who are more likely to spread COVID-19 to others because of their social behavior or employment, including young adults and teachers. The fourth group was people who live in areas with more COVID-19 infections. And the fifth group is, I can't read it on my own slides, people who are selected randomly through a lottery. And here you see the findings. Our participants were most in favor of vaccinating high-risk individuals living in group housing after healthcare workers. And then the second group that they chose most often was high-risk individuals living with their families. So we also looked at how people responded to these different groups being vaccinated first. So participants were randomly assigned to reading a scenario in which after healthcare workers, one of those groups shown on the previous slide was vaccinated first, but we did not assign them to groups that would prioritize them themselves. So every participant would have to wait. And then we added a control group where people had to wait for unidentified others. So I would get the vaccine once it became available to me, and yes or no, and I would avoid crowds and engage in social distancing as long as I was unvaccinated, yes or no. And so here you see the responses to that. In the control group, so it wasn't specified who was getting vaccinated first, 37% of participants said that they would not want the vaccine. Then the group that led to the greatest refusal of vaccine was people who live in areas with more COVID-19 infections. So if they were vaccinated first, then people would be least excited about it. That in 30% of people were already vaccine hesitant. There's some movement here, and which people get vaccinated first matters, but perhaps relatively little. And if you look at the logistic regression, we get that confirmed. So you see that the group that affects vaccine refusal the most is people who live in areas with more COVID-19 infections. But whether or not people were vaccine hesitant was a much larger predictor of refusal to vaccinate, of course. We also looked at their findings by vaccine hesitancy. So the blue bars here reflect people who had already indicated that they were vaccine hesitant. And among the vaccine hesitant, they were especially vaccine hesitant if they read a scenario in which after healthcare workers, high-risk individuals living in group housing would be vaccinated first. And then for the red bars reflect people who are not vaccine hesitant, and they also a percentage of them refused, said that they would refuse the vaccine after having to wait, but especially after having to wait for people who live in areas with more COVID-19 infections. And we see this in the logistic regressions as well. We also looked at a refusal to continue to engage in social distancing after having to wait. This variable was hardly affected by which group got vaccinated first. And 28% were already not social distancing, according to the self-reports on the UAS at the time. So getting overlooked by vaccine rollout may reduce willingness to get vaccinated if especially if high-risk individuals in group homes get vaccinated first, and this was especially true among the vaccine hesitants, and if individuals in affected areas get vaccinated first, and this was especially true among people who were not vaccine hesitant. Now, these main findings held independent of whether or not participants were already vaccine hesitant, but that was the largest predictor of willingness to get vaccinated. So given that there is some vaccine hesitancy among our participants and in the US population, we think it's important to start thinking about ways to increase vaccine uptake. I realize that currently we're dealing with shortages of the vaccine. So not everybody who wants to get vaccinated is able to get vaccinated at the moment, but we will reach a point where that hopefully is the case. And then it is important that vaccine uptake gets increased as much as possible. So it's important to make the rollout of the vaccine effective, fair, and transparent. But we also know from psychology and behavioral science that it's important to communicate clearly about the vaccine and how to get it, to make it easy to get it. So if you send people invitations to get vaccinated and you include an appointment in the invitation, people are more likely to get vaccinated than if they have to go ahead and make the appointment themselves. Currently, at least in California, I can tell you it has been my experience. It's very difficult to get an appointment. So I did get an appointment. It took me an hour to get it. I had to fight with a website. So if you currently want to get an appointment, you need to have the time to do it. You need to have internet access, and you need to be able to go to the limited appointments are available at the locations that they are available. So lots of challenges there. It's also helpful to leverage social norms. So if people see others getting vaccinated, they are more likely to get vaccinated themselves. We know that from the context of flu shots. And if we vaccinate people within their communities, then that will make it easier for them to get vaccinated, but also they can see their peers getting vaccinated. So this will be a good idea. There's the vaccine communication handbook that was recently published that suggests more ways of addressing people's concerns. Before I end, I want to highlight that thanks to this wonderful resource, the UAS, I've been able to write 8 papers on COVID-19 and people's experiences with it. And I have just checked with Jill, and currently I've learned there are 300 teams working on the UAS and the publicly available data. And so I think together we can make a big difference in terms of, understanding people's experiences with the on COVID-19. Thank you very much.
Thank you so much, Wendy. And we do already have a couple of questions from the audience. First came a question from Sarah Duma about why did you phrase 3, I assume she means the third group, as more likely to spread to others instead of more likely to be exposed to the virus?
Ah, yes, that is big. I'm trying to go back to it so you can see the wording. Here we go. Because we did that because Dana had done an analysis that suggested that if you vaccinate people who spread COVID-19 to others, then that will be beneficial to not that just to those people you vaccinate, but also to others. But you're right, we could have phrased that differently, and that may have made a difference in terms of how people responded.
Okay, and there's also a question from Andrew Parker. In Pennsylvania, I think it means, one of the groups getting priority are heavy smokers, I believe, as a high-risk group. Would you expect greater pushback in this case where there may be perceptions of choice and other negative associations?
My sound comes from a different place. Smokers were not explicitly mentioned in our survey, but I think in the context of lung cancer research, perceptions are that if smokers get lung cancer, they are to blame because it's their own behavior that led to it in people's perceptions. And so it may also, there's a perception that smokers should just quit. And of course, that's not that easy. As a former smoker, I can tell you, it was hard to quit.
And are there any other questions from the audience? Okay.
Can I add something just on top of what Wendy just mentioned on the heavy smokers? I think from a marketing perspective, it would increase the idea of unfairness, which would lead to even more anger towards not being vaccinated and someone else getting the advantage for something that they have chosen. So I think it would actually increase even more maybe the refusal to be vaccinated if I come after someone who chose to smoke, hence chose to be in the high risk, be perceived high risk because of that. But it's an empirical question. So,
It is.
yeah.
There's another question from Margie. Does UAS ask how long people spend to secure a vaccine, how they search for or secured an appointment, including computer versus an 800 number, whether the person went to a mega site or a pharmacy or where, how far had to travel, how long the line, all the logistics of securing a vaccination appointment and then getting the shot, which is, Wendy, what you were making reference to with your own experience.
I don't know if the UAS is asking about that. I haven't seen it. Is there anybody from the UAS who is? Jill, are you on?
The question was from Margie, are we asking in the UAS anything about the logistics of how people are getting the vaccine? Are they calling or going online? Are they waiting? Are they driving to a pharmacy or a mega site? All of those questions about how people actually go around getting the vaccine and the appointment.
Yeah, we have started asking a number of questions along these lines. I don't know the exact formulation by heart, but this pretty much is what we're trying to cover in the question. I think we started doing this in the most recent wave. So yeah, we're certainly trying to follow people's experience in trying to get a shot.
Okay. Well, thank you so much, Wendy, for this presentation. This was incredibly interesting and timely.